Welcome to Oncology Unscripted. My name is Matt Spraker, a radiation oncologist in Denver, Colorado.
My name is Katie Coleman. I am a kidney cancer patient and patient advocate in Austin, Texas.
And my name is Julie Johnson, and I am a sarcoma patient and patient advocate in St. Louis, Missouri.
We're teaming up to meet in the middle for a candid and educational podcast about cancer that is intended for patients, doctors, and their teams. This show and our opinions are meant for general informational purposes and are not medical advice. We encourage you to reach out to your doctors to discuss your individual case. Thanks for listening. Now let's get on with the show. We're back here with Oncology Unscripted. I'm really super excited for this show, for the topic and the guests. I think it's going to be great. Why don't we go ahead and just have you introduce yourselves, and then we'll jump right in.
So first of all, of course, I just want to thank you guys for having us on the podcast today, but also really for creating a space to have this conversation and talk about rehab, because I think it's something that we really hope to more broadly explore with the cancer community. My name is Hinrichs. I am a physical therapist. I received my doctorate in physical therapy from the University of Missouri, MIZ, for any Tigers who are in your audience. I clinically practice with SSM Health Physical Therapy in St. Louis, Missouri, and I also serve as the Revital Program Director, which we'll kind of get into for the Metro St. Louis area. I'm a board certified clinical specialist in women's health physical therapy, as well as a certified lymphedema therapist. And my clinical practice focuses on pelvic health and oncology. And my triple niche is complex pelvic oncology. So happy to be here.
Great. Thanks, Hill. And I'm Kelley Wood. I'm a health services researcher. My background is in clinical exercise physiology. So I'm a certified clinical exercise physiologist through the American College of Sports Medicine and also a certified cancer exercise trainer. And then my PhD work is in occupational and rehabilitation science. So my research is really health services based, really looking at how do we deliver and optimize rehabilitation services for people with cancer and use those services to really optimize outcomes in healthcare and oncology at large. So I'm the director of research for Revital Cancer Rehabilitation.
Thank you very much. This is super exciting. So I didn't know if maybe between the four of you, like if Katie, Julie, or both of you want to talk about the scope of this episode. I know that we had that like as our kind of first thing to discuss, because we all had a little bit of we had to take a step back and sort of decide what exactly we were going to talk about, because rehab and exercise is kind of a huge topic, right?
Yeah, absolutely. I guess I'll do a quick recap here because I know we all got together and met because this is such a large topic. And what we really wanted to focus on here is specifically on exercise and rehab in the context of kind of how to approach those conversations, things that can help, and kind of more kind of direct application, I think, is kind of what we're settling on for the most part for this topic. And I know it's one that I'm very excited about because it was something when we were talking about this that I think Julie had a little bit more direct experience in kind of a rehab scenario. And I had references to like things that I could do in certain situations, but didn't have more of that direct relationship. So I'm really excited for us to dive into these topics and explore it a little bit more, because I think it's really important for patients to know about and to know that they can very proactively get involved in the process.
Yeah, and I'm just going to add on to that because in my personal experience, I didn't know that cancer rehab was a thing until Matt, maybe the listeners remember, maybe they don't. If you've never listened before, you may not know, but Matt was my radiation oncologist, and he actually referred me to rehab during and after my radiation therapy. And prior to that, I didn't know rehab was a thing. I actually worked with a Revital therapist for rehab for a number of weeks. So, it's interesting to me because I went from having no concept that this was something to being an active participant in rehab, and can definitely speak to some of the benefits that I experienced during my rehab.
Thanks for sharing that. I think that in general, what I kind of pull out of that is how there's different exposure to these concepts I think that patients get in general. And I think a lot of that relies on their care team to be exposed to it. And then when we were talking, there was kind of like, what do we talk about on the show, right? Because you have kind of what Katie shared about how I think in general, a lot of patients probably get some advice or maybe like informal advice from either friends or family or their care teams about how to like, I guess, maximize your outcome by exercising, so to speak, or just being active, getting off bed rest, and then all the way up till like you're meeting weekly or every other week with a fully trained, experienced cancer rehab physical therapist, and that's a very different experience for two different patients. So for me, I think what I think was exciting about this show was kind of trying to make that connection for patients where if they do get the friends and family version of this, kind of like you should get up and move around, like how do you actually start to do that in practice? And that's something I struggle with as a physician counseling. So I can only imagine what it must be like for a patient if they don't have access to that kind of information.
Yeah, I think that's a great point, Matt and Julie. I appreciate you sharing your experience and your story. I think, it's funny because that's the number one reason why I went back to school to get a PhD. I was working in the community as an exercise physiologist with folks all throughout really their cancer experience during treatment, post-treatment, et cetera. And the number one thing I heard all the time was, why didn't I know about this sooner? Why is this the first I'm hearing that I should exercise? Why is this the first place, where I feel confident and safe, that I can exercise and actually alleviate my fatigue or make some progress on the deconditioning that I experienced during treatment? And so I think that's really our mission at Revital. This is what I research all day, every day. This is what Hillary does all day, every day in the clinic is we really try to provide these access to these services at large to help folks know that, we're your partner in your functional health. We're really looking out for you every step of the journey. We know how to anticipate a lot of those effects, that might be coming your way based on the treatments that you're receiving or other comorbid conditions that you have, and so our therapists, much like you might be referred to rehabilitation after a hip replacement, or if you have some kind of, musculoskeletal injury, our therapists are specifically trained to understand and anticipate those effects of cancer treatment on your body and really be able to help you to continue to do the things that matter most to you throughout treatment and then to optimize your health long beyond treatment.
Yeah, and I think one of the things that's really unique to the cancer community that I think is another reason why it's so important that they receive this information is that, so like the hip replacement that Kelley alluded to, we would never expect someone to know how to rehab after a hip replacement without guidance. That would be crazy. We wouldn't, to teach them the precautions, show them how to move, modifications for in the household, what strengthening and flexibility will look like and getting back to their lives as they heal. And for the cancer experience, this is sometimes includes surgery, often does, but it often is including other therapies or modalities, radiation, immunotherapy, chemotherapy. And so to expect a patient to be responsible for knowing what to do, it feels like a lot. And it is, because this is our entire skilled profession. And I think sometimes our patients feel the pressure to become an overnight expert on their diagnosis or on providers in the area or additional therapies. And they're researching so much. And this is something that our whole profession is designed to take that off your plate and to be this leader for function and quality of life, to evaluate you. So to answer your question, Matt, in like a short phrase, I would recommend really to be for an evaluation with a therapist who specializes in cancer rehab, for them to be able to help to know, who are you? What are you already doing? What do you need to do? Do you have a diagnosis? Is that potential to change? Like, are you having a surgery and you'll get more information then? Because a lot of times folks meet us and they're not even for sure what treatment will look like for them at that stage when we catch people early. So the idea is to meet with someone who is skilled in oncology rehab to really give that leadership and that direction to maximize their function throughout treatment and beyond.
Yeah, so this sounds like a perfect place. I know when we talked initially, I know one question that I had was like, if you were to define what cancer rehab is, if there's kind of a short description for it, as well as kind of when you're thinking about cancer rehab, I know as a patient, when I'm trying to process these, I'm often trying to think of like, okay, where do I fit in the context of like what's treated? So maybe examples of kind of the most common scenarios for cancer rehab as well.
So cancer rehab, in short, it's a program. It's usually provided by, there's 3 different disciplines: physical, occupational, and speech therapists. They're all in the rehab family, and they help cancer survivors achieve and maintain their maximal physical, social, and cognitive level of function within the limits created by cancer and its treatments. And so essentially, in the same way that if someone had an injury, and we'll kind of get in, I think when we talk too about the timeline of when you can opt in for rehab, it will help to kind of paint a picture of what that actually looks like. But essentially, in the same way that doctors and nurses can specialize in cancer and provide cancer-specific care, rehab professionals who really focus on your function and your mobility, they can also choose to focus and specialize in oncology. So a cancer rehab would be focused therapy designed to support your physical and functional health at the point of diagnosis, throughout treatment and beyond, and really also help to anticipate and minimize side effects, and then help restore those that we may not be able to shield you from throughout treatment. And I think some of the most common things I would say that we treat, I think the most well-known, widely known thing that we treat, sometimes we call those in the therapy world impairments or functional limitations, some kind of limitation that you have in your body, like could be stiffness, could be weakness, could be fatigue, but how does that impact your life and your function? So you may be stiff, but that keeps you from sitting at your desk all day at work because your back is bothering you. Could be have imbalance, and that could keep you from walking on a sidewalk to go get your mail. So we as therapists look at the connection between these physical limitations, sometimes can be pre-existing, then get compounded with treatment, and sometimes are new, associated with the disease itself or the way that the disease impacts your body or the treatment impacts your body. I'd say some of the most common things that we treat: weakness, fatigue, neuropathy is one. There's a lot that people don't know about that there are treatments for. So neuropathy is one of those. I'd say pain's huge. We see a lot of patients with pain, especially if they've had any type of soft tissue work, so like a surgery or radiation. We see people for chemo brain or like brain fog. So that's another one that I feel like is less known. Cancer-related fatigue. That's huge. The number one evidence-supported intervention for fatigue is exercise, but kind of what we talked about earlier, and I'm sure we'll dive into, is how do you exercise when you're already tired? So there's art and strategy to that, and that's what we provide. And actually, I'll make a plug here for pelvic health as well. That's how I got into cancer rehab. So I'm foundationally a pelvic health therapist, and I was working with a survivor who had dyspareunia, which is painful intercourse. And they were referred to me from their provider to work on sexual health and pain with sexual health. And it was in working with her that I was like, wait a second, there are so many other things that I can help you with that you're still healing from after your breast cancer experience that are just as important, in your physical recovery. And the patient had no idea that those things could be improved because she just kind of assumed that was just her new normal, which is, I hate that phrase. And so mostly because patients don't know what they don't know. And that's why they need leadership from healthcare providers to help say, hey, let's check this out. So what did I miss, Kelley? What are some other things that we commonly treat or that kind of helps to define cancer rehab?
Yeah, I think that's one of the biggest things is really just thinking about, rehabilitation. So our physical therapists, occupational therapists, and speech therapists, they truly are healthcare providers. They're board certified, much like any physician that you may see in a clinical setting. And their approach is very similar as well. So they're going to evaluate you to determine and to diagnose your needs, and then they're going to provide treatment based on your unique needs. What our therapists can really do also, it's a really huge skill set, is they're really able to look beyond whatever you may come into the door with. So you may be referred to rehabilitation for lymphedema or a shoulder because you can't get your arm up to receive radiation treatment, or because you're having difficulty managing your fatigue. But the therapist, because of their cancer-specific training, they're really able to look at your whole body system and how it's been impacted by cancer treatment, and how we can really work to optimize the entire system and help you get back to the things that you really enjoy doing. And so that's really the goal of rehabilitation as well. I know there's often confusion between rehab and exercise, and can I just go to the Live Strong or to my local gym, and really what's right for me, what meets my needs. And so really sort of the easiest way I like to boil it down to is rehabilitation is all about preserving and optimizing your functional independence. So if there is anything that is preventing or potentially preventing you from being functionally independent, whether that's your ability to work, your ability to care for your children, your ability to take care of your pets, or to do your yard work or your homework, anything like that, ability to drive, all of those things. Those are absolutely something that require skilled intervention, much like any medical need. And our therapists are really specialized in that. And absolutely that's part of the journey, and that's part of your way to optimizing your health and fitness through exercise. But a lot of people need an extra hand in helping them to feel comfortable and confident in exercising on their own. So that's always our goal in rehab. Our goal is always to discharge you much better than you came in through the door, and with your horizon being a healthy and active lifestyle.
So I wanted to jump in and sort of summarize what you said and then ask a follow-up question, because this is the first I've heard it framed this way, and I love kind of how you frame this. So basically, framing cancer rehab as a team-based approach to preserving independence or correcting something that might be threatening independence, right? And I think a lot of patients listening probably have heard or know of somebody that's had a knee replacement. That's like a very focused situation, right? Like, you know exactly what's going to happen in that surgery. You know the part of the body that's going to be effective and in what way. Like, knee replacements don't change the way someone interacts with the world in unpredictable ways. It's their knee, right? So it's their knee function, and you need to recover their knee function. And if you know any ortho teams, or if you know a patient that's gone through this, it's a very streamlined approach, and physical therapy is kind of right in there, right? Like, they're an integral part of the team. Everyone gets PT after a knee replacement. It's part of the strategy. So knowing that, it helps me answer to my patients, like, what's the difference between a personal trainer or doing your Peloton and then rehab? It's that question of independence, right? So if you're already a super fit patient working out all the time, maybe you don't need rehab today. Now, my question is knowing that cancer is way more complicated than a knee replacement, right? It can affect you in all different ways. You already mentioned brain fog, fatigue, fibrosis or stiffening of a joint, different joints. It's a lot more complicated, a lot more degrees of freedom than that knee replacement. How can patients make sure that they're empowered with their care teams to understand best whether they need just exercise at home? Do they need a personal trainer? Do they need a full-blown rehab team? Do you see what I'm asking? To really drive home that point for them.
So I think my dream and my manifestation for our cancer community is that, just like you said, how in orthopedics, PT is really integrated into the system and the process. Our goal is that cancer rehab will be part of that standard of care and part of that team for at least a consult, right? So you said they may have somebody who's exercising, and really what I recommend for people is to go and have an evaluation, even if it's for a home program and strategy. And so that's, I think, the difference is like someone's going to be saying, okay, like you're scheduled for surgery, you're doing really well, you're using the Peloton, you're going to be having systemic treatment. And I know that systemic treatment is cardiotoxic. So I want to get some baseline measures on you to get an idea of your overall performance status, how your aerobic capacity is. I want to screen you for these other things. And that way too, because we're also scientists and we want to have that data, so that, because sometimes that course of treatment can be variable, I want to have as much information about who this person is, so that if they come back and let's say they stay active throughout treatment, but they come back and they say, I still don't feel like myself. I'm not speculating and I'm not guessing what their performance status was. I can compare apples to apples and say, your 6-minute walk test used to be this. Your timed up and go used to be this. And so let's see how you feel when we use this data and try to get you back there, functionally speaking. And then at the same time, the artistry is weaving in those things that they care about and making sure that they can continue to ride the Peloton safely. So, for example, too, another piece, metastatic disease. I think we mentioned this in when we were talking about the call. Sometimes, if something comes up and we might need to adapt strategy to be able to, or someone who has metastatic disease that's active, let's give you focused guidance on how to be safe and still live your life moving forward. So I think in terms of that risk stratification, or who needs to go, I really recommend, I think in a best case scenario, everyone would go for an assessment, so that we can really help to lean into that entire continuum and not just be reflexively treating impairments or limitations or side effects as they come up, because then often it becomes a little bit more challenging to address because the level of acuity and like how further developed these symptoms may be more complicated. Did that answer your question?
It does. Yeah, no. And I think, and just to drive the point home for patients, I think that at the end of the day, I should just say that this is something that may not be available to every patient today, right? That's the dream. Like you said, you want everyone to have access to these clinicians. But I think it does drive home the point of what the difference is, right? Between exercise on your own, a trainer, and then a clinical physical therapist, occupational therapist, speech and swallow. It's just the level of content expertise, the integration with the team, and then focusing, for example, you're not, training on a Stairmaster so you can like walk more stairs and feel comfortable. That's part of it. But you may be training on a Stairmaster to feel more comfortable, but then also following your 6-minute walk test or other data points to try to intelligently address this in anticipation of how the therapies or the cancer itself may affect someone in the long term. Hopefully that's good for people, because I think it's a really good explanation of the difference there, which is not an easy thing. And a lot of people get caught up on that. Yeah.
And I think too, exercise is a prescription, right? So when you're thinking about like, if somebody goes to the gym and does squats, like certainly not everyone needs to do squats. I may be prescribing squats for one of my patients, but could be totally different. It could be because they squat to pick up their grandchild and they need to be able to move and maintain the strength to be able to do that. So it's the intention of the things that we are recommending and helping to support them to do.
I think the one thing that I just want to add is, Matt, you made a comment, just your most recent comment about, maybe if somebody's really active and exercising a lot, maybe they don't need rehab. And I'm just going to link that back to what Hillary said, because I think when I was going through treatment, I would have been the person that felt like they didn't need rehab because I was so active. I was doing, I remember I was going through radiation and you were like, so are you staying active? And I was like, well, I mean, I'm running a little bit. And you're like, well, how far are you running? And I'm like, well, I mean, I ran like 3 miles today. And you were like, oh, okay, 3 miles. And like, I don't say that. The only reason I'm like sharing that is because you probably will run across a lot of patients, or there's patients listening who are super active, but they still can benefit from rehab. So for me, I didn't realize the range of motion, the range of motion issues that I was going to face after multiple surgeries and radiation. Like that was not that did not register with me that I would not be able to lift weights the same way because I was so active and I was doing a lot of strength training and weightlifting that I was going to have to change the way that I was lifting weights, maybe even the way I was holding the weights, when I was doing things overhead. And so that's when I was able, when I shared that with my therapist, that's when we were able to develop more of a plan that would help me get back as much of that range of motion as possible and still give me tips and strategies on how I could get back to as close a level of exercise as I was doing previously. And I could still have the mobility needed to do those day-to-day functional movements, like taking something off of a shelf or lifting something onto a shelf, things like that. So I just want to echo that in an ideal world, I think everybody, regardless of how physically fit they may or may not be, can benefit from this, because it really is about retaining the functional kind of daily movements that you do in life and in exercise. And one of the questions that I had was, I go back to my own story again, and I think about how Matt brought this to my attention. And I remember I asked another person on my care team about it, and they were like, oh, I don't know why you might need that. And so I'm just curious, when you think about how widespread is knowledge and awareness of cancer rehab among oncologists? I mean, are there certain disease diagnosis settings where, it's very well known and you're closer to that ideal setting of seeing patients often? Or can you just speak a little bit to how widespread is an is there in terms of understanding of cancer rehab among oncologists, whether that be surgeons or medical oncologists or radiation oncologists?
Yeah, Julia, I think that's a really great point and a great question. I think in terms of the world of cancer rehabilitation, it's really an emerging field. So it's been around since the 70s and the 80s. But in terms of really being integrated as a standard of care, where, it's widely understood by medical providers and also by patients, much like you would think, I'm getting my hip replaced, I'm going to have PT somewhere in my future kind of a thing. Really awareness about the benefits and the access to cancer rehabilitation services is really grown, exploded here recently in the past 10 years. Just this past week, national standards were actually released for cancer supportive care from National Cancer Institute in the VA, and they actually named rehabilitation as part of those new national standards. And so currently about 70 or so different oncology clinical practice guidelines do recommend physical and/or occupational therapy in some capacity. Some are a little more specific to the prehab side of things, like Hillary was mentioning, in terms of really getting that baseline assessment, the education in the home exercise program to be able to, to anticipate any possible declines and help really restore that function. And then others are more broad in terms of when rehabilitation should be utilized. So that's something that I work on quite a lot in terms of triage and when's the right time and what's the right program and what's the right service for any given person. So it's definitely a growing and emerging field. Some of the latest research, like survey research, has been done and really has a wide range. So there's studies out of Canada showing that as many as 80% of oncology clinicians are not aware of the exercise guidelines specific to folks with cancer, which is 150 minutes or more of moderate intensity exercise per week in resistance training after treatment, and 90 minutes or more of exercise during treatment. And all of that is from an enormous amount of research really showing that exercising at or above that level is associated with not only better treatment outcomes, but also lower risk of cancer recurrence and survival. And so that's really where that evidence and data is coming from. But like I said, survey studies are really broad, showing a low general awareness among medical providers and also among patients. So it's something that we're actively working to raise awareness. And I think one of the big efforts that's needed is the access to these types of programs. So if you alluded to, Julie, you had Revital program, where you receive treatment, but many folks don't. So if you're not receiving treatment at an NCI designated cancer center, for example, or in a large metropolitan area, it may very well be that you don't have access to someone that is specialized to treat your cancer. There may be other physical and occupational therapy services and exercise, of course. But in terms of that specialized care, those are growing in popularity. And as they grow, of course, we become more integrated into the oncology care team. So to kind of answer your question, I think, if we take a large snapshot picture, I think awareness in general is relatively low, but there's growing pockets in the United States, in Canada, in Australia. They're doing a really great job where there's a big increase in awareness and big integration of these services across oncology.
Yeah, I have a couple questions on the access, because when I think as a patient, we talked about not everybody has access to it. And like, if we're taking the stat of like 80% of oncologists don't know that these programs exist. So I kind of have two questions there. One is like, how does a patient like even know how to ask, where to ask if they search it out on their own, as well as from like a kidney cancer perspective, for example, I see all the time in support groups and talking with other patients who have kidney cancer. So kidney cancer is one of the cancers that surgical interventions happen most often for patients in earlier stages. And they're starting to move into adjuvant treatment a little bit for the more aggressive disease. But for the most part, surgery is kind of what's recommended early on. And so when I think of those interactions, I don't know if like interacting with a urologist, for example, would know to refer to rehab. But I see in patient support groups and talking with other patients all the time of like, I'm 6 months out from my surgery and I am still super fatigued. Like they're telling me I should be recovered. Or for example, in my own particular case, and I was on systemic treatment and then had surgery. But for me, like I had surgery. I was told I should be pretty much back to normal at about 6 to 8 weeks, but I wasn't back to normal. And one of the things that I think we talked about when we were brainstorming this podcast was like, I still couldn't laugh without pain, or I like was doing this weird hook maneuver with my leg in order to like sit myself up because I didn't have the abdominal strength to actually like be fully recovered from surgery. But I didn't know that there were interventions for that. And especially like for earlier stage patients or even before my own surgery, like I wouldn't have thought to be evaluated beforehand to know this was my baseline and this is what I am at now post surgery, which feels like it's actually a very important metric because I know I would have felt that way. And I feel like I hear that in other patients as well, too, of you're being told you should be fully recovered, but you're still feeling fatigued and there's no way to provide evidence of that shift. And so it can make you feel like, okay, is this all in my head kind of thing? And as a patient, that's like one of the worst things to feel. So I know that was a lot in, in two statements and questions, but would love to hear your guys' feedback on that.
Yeah. So I think, and this kind of ties in with Julie's question too about provider awareness. I do want to make sure that we let people know it's okay to ask your doctor and not have the right words, or your care team. And you're like, I don't know who to ask. Somebody, the idea is like, we're a team, right? So the more we know about like our own area of specialty, we also, rely on each other in our networks. And so I think going to your provider, whether that's the urologist at like a point of entry, I actually work with a lot of really amazing urologists. And so many of them know a lot about rehab, and I see a lot of prehab referrals from urologists. But that is because of the environment that I work in, the providers that I work with. We've been on a team for a long time. And that is my hope more broadly, again, as things develop and as the awareness and the integration of rehab services becomes really part of this continuum. But even if, let's say, when I first started working in this space and I would go meet with urologists and I'd say, hey, did you know that I really love working with these people? There's a lot we can offer for them and we really can help support them. They would often ask me like, oh, like what would you do? And so I think that we're all learning. And so if you were to go to a provider, I think the conversation could sound something like this. Hey, I listened to a podcast and I heard these people speaking about cancer rehab. I'm interested on how that may play a role in my care. Do you have a resource for me to be evaluated by a cancer certified therapist, a therapist that specializes in cancer rehab? And if they don't have a resource, you might have been that entry point for them. You could help to create that resource, not only for your own experience, but also help that provider to find a therapist that then maybe they just don't know who specializes in cancer and they're afraid to refer out because they're afraid that we're going to overdo it or that we won't understand. And that's why, again, like I really think that identifying someone who has had specific training in oncology, like our Revital team, like we have a website. A patient could go to the website and they could put in their zip code and they could look up a therapist if their provider doesn't have one. So there's different ways. But yes, I think that the answer to the urology, like, could I ask my urologist? Absolutely. And if they didn't know, again, this could be the introduction point for them.
I absolutely love that you pointed that out, just because myself as a patient, especially as I've learned to advocate more and find resources on my own, I actually know that sometimes I can go find a resource on my own, but sometimes I ask through my provider for that exact reason is I know like somebody else is going to have this question at some point. So if that connection doesn't exist yet, let's make that connection. And we can use me as the person who kind of helps explore what that is. To be able to help that be available for more patients. So I love that you provided that language to be able to help other patients do that too.
Sure. I mean, we learn things from each other, right? And some things are going to be in the textbooks that we learn through training. Some of them are through experiences. Some are worked through that multidisciplinary work. I have a notes document on my computer of things that resources patients have told me about that I never learned about. Books that really resonated with them, people to follow online that really helped to provide them support. So I think that this constant utilization of resources between, the patient and their care team is just really important to be able to keep them in the center.
So I want to add one thing just in just from the clinician's point of view, just to drive home the point for patients that it is true that like even sometimes NCI designated or COC accredited are two very common programs patients might see. The bar to become accredited is not very high with respect to rehab services. So like, for example, I know the COC criteria very well. It's not a knock on the program. I think it's important. But if I can just show the COC that I can refer to a physical therapist, that's all I need to be able to say that I have a good enough program. And if everyone's listening to you talk, obviously we need more than that. But it really, like, I think that patients, it's just good to recognize that even some of the top centers probably could use a bit more in the way of resources for these services in general. They're generally not as well supported as some of the other aspects of medicine or oncology, like delivering the latest systemic therapies, the latest radiation technologies, or the latest types of surgical technology. Hospitals may have that. They may have a robotic surgery suite, but not cancer rehab physical therapy team, right? So I think it's just important for people to kind of recognize that. The other thing is I want to just post, I think it's worth sharing in the show notes. We can do not only your website, but there's a couple of other licensing bodies that can like, where you can literally just like type in your zip code and it'll tell you like a good cancer rehab physical therapist. So we'll put those in for people. And then I thought it might be worth linking, you both must be familiar with Dr. Schmidt's paper that is it's two clinicians, right? So it's for people like me that are not specialists in this space, but see patients with cancer, and like, how do you approach that? And I think it might be good for patients to see that if they're interested in like a higher level of learning about this stuff, just to understand kind of where we're at, because it's fairly basic, but it's a lot more information, I think, than most physicians probably have when they leave training. And so I think that your group and your colleagues have done a great job to educate physicians, and we can kind of share where we're at with that, and that way patients can see kind of what we know, right? And so that sort of helps give people all on the same page and kind of work through this kind of confusing space.
I think that's a great point, Matt. Are you referring to the assess, advise, and refer framework, Dr. Schmitz?
It's called Exercise in Medicine and Oncology, Engaging Clinical. That's the one that I keep referring back to.
I just thought I'd add some color to that. So what she's really recommending in that is asking patients about their current physical activity level during treatment. So whether or not they're meeting those guidelines we talked about earlier. So that's the 90 minutes during treatment or the 150 minutes after treatment. And then for those who are not currently meeting guidelines, they recommend using ECOG or performance status in some level. So therefore, folks that have an ECOG greater than 2 would be referred to rehabilitation or other exercise services where there is a cancer specialized clinician there. And Dr. Schmitz and I have actually been working on this work a lot together, and we've developed an algorithm as well that we'll be launching to the public here in a couple of months. So it'll be an open access algorithm where anyone can go put in their information and be matched with the most appropriate level of services based on their needs. So I'd be happy to share that when it's available as well.
Yeah, and I think it just goes to speak to, this is not something that's in a lot of oncologists' wheelhouse, right? And so I think there's a lot of education to be done. It's just a systems issue that I think is getting better, like you all mentioned. But I think, we want to get to a place where every patient kind of has access to that level of care. Yeah.
Can we pause for a second? I usually do this when there's terminology that comes up.
I was going to the same place.
And I've called Matt out before for using heterogeneous. Is that the one that I called you out for? All the time. It's a favorite word. But is there any way that you could explain what ECOG status is? I know as a patient, when I was like trying to learn kind of even how to interpret studies, I mean, that is used all the time in assessing patients. And I know it just came up here. So I don't know if Kelley, you can expand a little bit further on what ECOG status is and kind of how that's used in cancer rehab, but kind of just in general in oncology as well too.
Yeah, absolutely. So ECOG is a performance status scale. It's a way of rating how well someone is doing in terms of their ability to do daily activities. ECOG just stands for Eastern Cooperative Oncology Group, I believe.
Yeah.
Okay.
Yeah.
All right. Thanks. It's like, don't want to mess that up. So it's like a 5-point rating scale. Matt would know this much better than I would, but it's commonly used in the oncology space. A lot of times it's used to dictate whether or not someone is suitable for certain types of treatment, or also if they're suitable for clinical trial. So that's the way it's commonly used. It's a 5-point scale where 0 means that you're fully active. There's no restriction in your ability to do your daily activities, function, work, etc. And then 4 is completely disabled, totally bedridden, and 5 is deceased. The framework by Dr. Schmitz, the recommendation is that anybody that will be a 2 or greater, so meaning you're able to ambulate, and sort of get up and move around, but you're having restrictions in daily activities. Those are the folks where we sort of draw the line in terms of needing rehabilitation care.
Yeah, and I think it speaks to the so it's, yeah, and to be clear, it's a great description. It's basically a research metric, right? So we do use it a lot in clinic, but sort of inappropriately in my opinion. And what she's sort of saying here is, like, if you're an oncologist, not an expert in exercise or rehab, but you're planning to, like, advise them to exercise or do some kind of rehab or physical therapy, you might do something different for a person that's bedbound and requires 24-hour care from a caregiver versus someone that is riding a Peloton every day, right? So they may both have a need to be referred to that person, but you might do something different with them, and that's why that came up there. And so it's the document or the article that I'll put on the show notes is genuinely intended for clinicians. It's not really for patients, but I know that a lot of our listeners and both of you like to read that stuff, and I think it would be informative from someone that's very interested, just to understand how the experts in this space think that general oncologists, non-experts, should begin to approach this with their patients.
Yeah, I think it's important. I know not every patient gets involved in, especially like getting involved in kind of reading some of these research papers, but there are a lot of patients that do. And I do think that not understanding that terminology can be a little bit confusing. I know as a patient myself, I have recently dug through my records to try to figure out where my ECOG was like listed at when I was first diagnosed, because it's also not something that's shared back, but clinical decisions are made off of that sometimes, right? So it feels weird as a patient for there to be a metric you're tracked against, but not be one you're informed of. And so just wanted to pause and highlight real quick what that was and describe it a little bit in more detail. So thank you.
That's great. And I just want to add one point. We can't go off on a tangent because otherwise we'll talk for an hour, but there's new research actually showing that the metric is quite poor at predicting anything. It's actually not, it's a pretty useless metric in my opinion. It helps to communicate a little bit between doctors, but nowadays, if you, for example, take a step counter, like just a pedometer, like a Apple Watch or whatever, and you use that metric, just the number of steps per day, and you compare that to what the doctor assigns an ECOG status. So again, this is like the doctor in your chart saying, here is your performance status per this grade. The step counter is actually a much better metric of like how you're going to do in the long term. It's a very general statement. Please don't take too much of that. We'll have to talk about it some other time. But it just speaks to the challenges with that metric of ECOG. Yeah.
Mm-hmm. But also the importance of functional health and performance status and the ability to make those treatments. And again, how rehabilitation can really provide value on the oncology team and to all the patients listening in terms of really being able to understand your functional needs beyond a 5-point scale, perhaps, and to really help you to understand and anticipate those needs.
It's capture your entire life on a 5-point scale, right? Yeah. I was wondering if we could pivot just in the interest of time and try to, I thought the topic of talking about the role of rehab at each phase of treatment. And I thought we could try to be a little general with it, just so it applies to both sarcoma and kidney cancer and other types of cancer. And because you mentioned already some of the symptoms that I bet a lot of people are not super aware can be helped by cancer rehab. And so maybe just going through where rehab specialists can help at each of these phases. And maybe we'll just generally call them diagnosis, pre-treatment, at the time of treatment, which might include a surgery. And maybe we can focus a little bit specifically on surgery, and then post-treatment, or like in quotes survivorship, when people are kind of done with treatment and doing surveillance.
Yeah, so I think I'll start actually on the later phase, because I think foundationally as therapists, so as rehab professionals, we're trained to treat impairments, like identify a problem, try to resolve the problem or improve the situation so that people can live their best quality of life, right? So historically, and especially, when like the patient that I mentioned earlier, she was sent to me with a complaint, and we call that like impairment driven care. And oftentimes if someone's been through the continuum, so they already went through active treatment and they're transitioning towards self-management, and that's where they are at their phase of survivorship. And they're maybe trying to address side effects, so pain, limitations, or symptoms that they're having at that point. So we absolutely provide care there, and that is, we call that impairment driven. We're addressing a problem that exists. And then for those of us who have been in this space for a while, we've been treating this way as physical therapists or occupational therapists or speech therapists. We're used to getting referrals for, hey, this problem was flagged, and so we're referring here for this. But with cancer, we started to be like, wait a minute, we could do this so much better. So for example, I love this analogy because I think in St. Louis, for those of you who experienced St. Louis winters, if I knew that it was going to snow, if I was like, okay, tomorrow we're going to have a snowstorm, I would not just wake up and see how the day goes and just face the storm without having any type of like context. If I could forecast and I was told, hey, this storm is coming, it's going to happen tomorrow or the next day, and this, I could start to prepare a little bit. I might choose to make sure that I had gas in my tank, or maybe just check and see if I had gas in my tank and have that awareness. I might put some salt outside. I might dig up my boots from the basement and make sure that I was a little bit prepared. And I might wake my children up a little bit earlier to start my day so that I could have a little bit of a way to kind of manage what to expect, and then have some tools to set me up for a little bit more success, so that if things change or if things are not as expected, I have those resources already teed up. And I feel like when someone's diagnosed with cancer, we have this opportunity to forecast. And so that's really what started this prehabilitation, or this early model of saying, hey, wait a minute, let's not wait to address side effects. Let's meet people at the point of diagnosis. And that's where a patient could come in and maybe they have a diagnosis, maybe they have a potential diagnosis, but it's waiting until it's confirmed with a surgery, and they have to determine what needs to be done at that point. But we could say, okay, here are the things we can forecast. This may be a part of your health trajectory. And here are ways that we could first assess if you have any pre-existing issues, or if there's anything that we could optimize for you, right? So let's say that you already had some chronic knee pain and we are anticipating that you may be having like a limb procedure or on some agents that are going to make you fatigued. Like, we don't want to see what happens with your current knee pain. We'd like to try to optimize that knee, strengthen you ahead of time, and get ahead of things. For my pelvic patients, many of my patients have pre-existing urinary or bowel issues. And so one of the ways I try to give them a head start is to help to normalize those pre-existing impairments so that they're not compounded with treatment. So prehab could be this baseline assessment to get an idea of how someone's functioning, and then also prep them for surgery. Matt, you mentioned surgery. Hey, like, it feels to be able to tell a patient, hey, this is the surgery that you have planned. Here's what to expect. Here's actually what you can start probably post-op day one, especially if I have a relationship with the surgeon and I know what their preferences are in the way that they do their procedures. We can even talk about what to expect for that first week at home so that people aren't as afraid to move because they have some of those guardrails. Here's a way to safely get in and out of bed, and especially those hospital beds, which are so tricky. Here's how you should sit on the toilet. Here are things that you can do to how to gauge your activity to know if you're doing too much or if you're doing too little. So on the front end, equipping people with that information and giving them that power to be actively involved in that recovery rather than saying, what should I expect for today? And then, Matt, you mentioned too, like those going through active treatment, right? So many of our patients and I also want this to be clear, because for those of you who are listening and maybe you're going through active treatment, or maybe you're on the other end of survivorship and you're thinking, gosh, it's never too early and it's never too late to get plugged in. There's no expiration date on your potential. And so I think, just as I'm framing these three different kind of entry points, just know that it's always available, and our bodies are designed to be malleable and to learn and to adapt and change. And you're just getting partnered with somebody to guide that. So many patients do enter the system like while they're going through active treatment. And that may be for endurance and strength throughout systemic treatment. That could be pre and post surgical care to help restore function. And that could also be what we call prospective surveillance. So establishing a relationship and understanding who the person is, and then reassessing at high risk point intervals. And so for example, let's say that you're going to start systemic treatment. You're doing really, really well. Maybe you don't need to see us. Great. Let's get you a home program that's specific to you. And then let's check in depending upon which therapy you're on, 3 to 6 weeks, when I would expect a decline. So I'm forecasting and establishing your care based on who you are and what treatments you're receiving and how that lines up with your needs and availability. That's a lot of information about the continuum. So now you should be an expert.
I really liked the what you mentioned about surgery. Again, kind of going back to a kidney cancer example, and especially with early stage patients. Like, I always am a very big advocate on supporting patients when they're initially diagnosed, because I feel like it doesn't matter what stage you're diagnosed with. The first time that you're told that you have cancer is just this like sinking feeling. You are at a point that you probably don't know what the reoccurrence rates are, and you're not sure what to expect from treatment. And there's a whole lot of waiting between when you first get that diagnosis and when you have your first appointment, maybe to find out what your treatment is going to be, and then to when you actually are going through surgery or whatever treatment may be. And I know something that I felt, and what I hear a lot from other patients, is there's this window where you feel like you're just like, it's kind of like a hurry up and wait. You're just left with a whole bunch of like, what can I do? I don't know what to do, but you really want to be proactive. You're in a period of time where like, it feels like there's not a whole lot you can control. And so finding out what you can control, like maybe getting involved before you have the surgery, is something that you can take action on. It's something that you feel like you can move forward on. I know as you were talking about that, one of the things that really stood out to me is like knowing kind of what to expect after surgery. I know I brought up when we were kind of planning for this podcast, when I was preparing for surgery, like one of my surgeons had mentioned, I mentioned like, is there anything I need to do to prepare? Like, I used to run a whole lot, and I personally was petrified because I had like a pretty massive tumor, and I was like scared to run because I was like, I don't want to rupture the tumor or anything. Like, is there anything I need to be cautious of before surgery? And the main advice that he ended up giving me was like, no, just kick it up a notch. Like if you're walking a bunch right now, like maybe just kick it up a notch. It'll be able to help you through surgery and kind of the recovery process. But that's kind of the only guidance that I got in that area. And so like being able to have like a more integrated approach would have been helpful, as well as I know me personally as a patient afterwards, I kept hearing over and over again how important it was to like get up and get moving, but I had no idea what that meant. And I'm a very like metrics driven person. And when I was in the hospital recovering, I was given very specific metrics. Like, I want you to walk 16 laps today. So like I would go walk 17 and put them on my little board. But then once I left the hospital, I had no idea. And the only thing I went based off of is like talking to other patients and finding out what they were doing, and then like gauging myself off of them. And so I really love this idea of getting involved sooner so that you know kind of what those benchmarks are and that they're tailored to you. Like I was trying to benchmark myself off of other patients, right? And we all know that that varies depending on kind of what we just talked about here of like what your abilities are beforehand. So I love that approach. And I do wish that it was a little bit more integrated into patient care.
I think too, Katie, when you're talking about exercise, essentially kind of you're leading to is like prescription, exercise dosing. And same way that your doctors dose your medicine, we help to give you those parameters. And so we would use tools like the RPE. So what that means is it's the rate of perceived exertion. So essentially we can teach a survivor, hey, this is how hard you have to work to get into the sweet spot. And that sweet spot is where we're going to expect a clinical, meaningful change. And so we're going to help to provide that dosage, because activity, and we kind of talked about this earlier, activity is good, but it's different than focused exercise that gets you to a level where we would expect that you'd get that return so that you wouldn't feel as fatigued. So I think that that's the other piece is we'll help teach you silly algorithms like the RPE scale so that you would be able to self-gauge and self-assess and monitor your own progress.
Yeah, I think that's fantastic. When I think of my own like recovery through treatment, I mentioned again, I was trying to benchmark myself against other people. But I remember for me specifically, I had my surgery at the end of June. It was really hot. So I got back into Texas in July. And I remember I was trying to be more active, and it was so hot that I like walked outside and was just trying to pace, like, I had an apartment. And so I had like a little pet yard, super tiny little yard. And I was trying to pace that. And like my heart rate was in the like 160s, like doing tiny little laps around there. And like I was completely exhausted. And I know how much I beat myself up after that, because I was like, man, I can't even walk a tenth of a mile without my heart rate just going crazy in the heat. But again, that I think kind of goes back to what you were saying. Is like, I had nothing to gauge off of. Like, I didn't know if that was expected for me. I didn't know how to moderate that. And I kind of just had to slowly learn that on my own.
Katie, I think that's a great point. I'll just add to that for a moment. I hear, a few things from you and your story, which I think is so fantastic. I think the uncertainty, I don't know about you, Hillary, but I think that's bar none the most widespread thing that I hear from patients is this uncertainty around what I should be doing, what's going to help me, what's safe. And I often, just like your example, hear it coming down to, well, I tried to do this, but I felt like my heart was beating out of my chest. And I did this, I used to do this, and now it feels totally different, and when I work with the people in the community, I used to often get this sentiment, especially working with women, of this idea of like, I just don't really trust my body anymore. Like, is the signals it's telling me, is that real? Is that from my like, what is that? And so I think that's yet again another way that your therapist is your ally, your partner, to help you understand those new signals that you may be getting from your body. They can help you understand why after that, the chemotherapy or during the chemotherapy, your heart rate response to exercise is going to be different, and that it's okay, and that, the heart is a muscle and we can continue to train and improve that, over time. So absolutely, I think that message is going to resonate with a lot of folks, and is, for a lot of us, is the reason why we do what we do. We really feel very empowered by the ability to just help people in the time of such high levels of uncertainty to do something that's going to help you to feel empowered and active and engaged and in control.
Absolutely.
Yeah, I love that you use that language of didn't know if you could trust your body, because that is something that like has happened to me, like, and I still even struggle with sometimes, right? And I'm 3.5 years out from my diagnosis of like trying to figure out like, is this a symptom? Is this like to be expected? Like all those benchmarks. I think once you get diagnosed with cancer, especially I know for me, like I was diagnosed with such a late stage cancer that I had that feeling of like, I don't know if I trust my body to warn me for things, and I don't know when it warns me if it's a real warning or not. So knowing what to pay attention to, I think is great context to be able to provide.
I think the other thing that happens is, I think everybody kind of assumes that cancer brings a new normal, and I think, but nobody knows exactly what that means. They just know things are going to be different, but they don't know how, or there's just not, it's just the saying that things are going to be different and you'll have to find your new normal. I think one of the interesting things that we talked about too, when we were prepping for this is, maybe that's, if you find yourself saying, oh, this just must be my new normal, like maybe that's a sign or a signal that maybe to ask a few more questions, because it may not have to be your new normal. And I thought that was really interesting when we talked a little bit about that.
I think if another thing that I could just have like the whole audience like walk away with today is just not to settle. In my experience with like working with survivors, again, people are, and I think we've seen this, like patients and survivors are less likely to complain about a symptom, because they will just say like, I can deal with it. It's something I can manage. This isn't, I think that the medical offices, we've trained you to triage symptoms, like what's high risk or what's something, but also at the same time, like if you can't sit comfortably, or if you're showering because you can't get in the bathtub and you love taking baths, like that is valid. And I think that until you've been assessed by somebody who says, or until you've explored things, like you don't know if it can get better. And so I think just, the assurance to not assume that this is the way it is, and not to settle, and not to feel bad to say, hey, like, I know this isn't like top tier in like the screening when I come to the doctor's office, but like, I really want to take a bath and it hurts, or my tailbone hurts, or, like I still get winded when I am trying to chase my kids, or I want to be, we have people who are athletes, even in, I think that we have to be really careful with ageism in oncology as well. And I think that that's something that, it's really important to call out as well. And so I think we need to not make assumptions about how people's athleticism changes throughout a diagnosis or throughout their course of treatment, and what their goals may be and how they engage. People are playing pickleball. And that's a big sense of self and identity, and that stuff matters. So I guess that's my offering, is to just feel comfortable talking about the bits of you that are impacted by this experience, because it's impacting your whole body and your whole persona. And that's part of rehab, is just helping to make sure that we're staying ahead of those things.
I love that you brought that up, because I know we talked about that a little bit before as we were prepping for this, is the fact that, and I think to me that fits really well with the kind of how you talked about like how to bring these things up in appointments, because one of the things that I think about all the time is that I was told I would be like fully recovered at 6 to 8 weeks. And in my mind, I was like, cool, I'll be back to normal at 6 to 8 weeks. And then I wondered at 6 to 8 weeks, one, was I falling behind? And then two, how my providers or these websites, hospital websites, could be so off on what being back to normal was compared to what I was. But then I also mentioned how I contributed towards that, because I went into my follow-up appointments at those timeframes and I was doing so much better than I was like a couple weeks prior, that I was so excited to share with my physicians of like, yeah, I feel great. Like I was able to walk down the street and I was able to do all these things. And I told them that I was feeling back to normal, where it was still hurting to laugh. It was still hurting to like bend over and pet my dog. I still had to do that weird maneuver to sit back up, but I didn't think to mention any of that stuff because I was so excited about the progress that I had made. And it didn't feel like an intervention that they could help with. But in our context that we're talking about here, of like knowing your baselines, knowing that there's these other resources, like I probably would have engaged with the other resources and they would have gotten that full context, because it didn't feel like something that like needed a medical intervention from like the context I was bringing it up in, like a surgical intervention, right? So it didn't feel like something I was addressing in that standpoint, but it very much wasn't my new normal, for example. So I love that was highlighted.
And I love what Julie said. It's like, if you start to think that, maybe this is your pause button, like take a second and think like, maybe this is something we should explore.
I would just add to patients, like that they should have a completely open mind with respect to what you just said. Even not thinking about, or even like to the point where if you think, oh, well, this is not something a therapist can deal with. Like, and this includes like sexual side effects, like things that aren't even just movement, right? I think a lot of people realize like PT helps with shoulder pain or knee pain, but anything, like I'd bring it up to a doctor or a rehab professional if you're seeing them, because it's not as reductionist as medicine usually is, where we have like a gene and a targeted drug and we give it and it works. This is like you have a subtle way that a patient's life has been changed by the tumor or treatment or both. And then that plays out as an interaction with how they interact with the world. And every patient interacts with the world differently. And so it's just so complicated that I wouldn't, like, if there's anything that's a problem in your life, like I just encourage my patients to come and tell me about it, because a lot of times we do have a solution, or at least a way that we can work on it, as opposed to just sort of living in this quote new normal.
One thing I wanted to ask, and it's a little bit of a pivot from what we've been talking about, but I know often when anybody recommends something to me, one of the questions I always ask, just because I think it's a question to ask no matter what's being talked about, is what are the risks? And, I know we've talked a lot about the benefits of rehab. We've touched a little bit on the benefits of exercise, but for patients out there that are listening and this might be new to them, like, are there any risks that patients need to think about or to consider prior to rehab or during rehab? And that's probably going to be very, dependent on the situation and on the patient, and there's a lot of individual context there, but just broadly speaking, are there any any risks that patients need to be aware of?
Yeah, Julie, I think it's a great question. And I think your approach is spot on. Of course, any new information, we always want to think about risk. There's risk associated with everything. So in terms of, the average patient, there's very, very low risk in terms of participating in rehabilitation. Now, there are risks associated with independent exercise, especially if you are not someone that is currently active, especially if you sprinkle on a few conditions, if you've got a heart condition, diabetes, a lung issue, anything like that can impose risk in terms of exercise independently. And so that's one of the number one reasons that we want people to come to physical therapy, even folks that might already be active or folks that, don't have obvious impairments, is because, our therapists can really understand those risks and help you to exercise safely on your own. There's also lots of, clinical exercise physiologists, folks like me and my background, who are also adequately trained to help you to navigate those risks as well in the real world. So in terms of risk of rehabilitation, there's really no, explicit risks. I think that in coming in, there are a lot of risks associated with cancer treatment. So perhaps things like complications from treatment that might result in a dose delay or things like that. Also wound healing complications. And so that's where our therapists can really work hand in hand with your oncology team, for example, by understanding any restrictions that your providers have placed on you, whether that's after surgery or during rehabilitation, or perhaps you have a port. Our therapists are trained specifically to be able to sort of work around those issues to minimize any risk that might be associated with any treatments that you're given.
You did. You said that very eloquently. And I think that when you think about that care team, I just would echo what you said about working with somebody who really understands the cancer experience and its treatments. So, for example, I actually see us as another layer of support to screen for additional risks. So, for example, if I'm doing a baseline visit for somebody and they might not even be aware that they're at risk for falls, but on my assessment screen, there's a test. It's called the TUG. It's the cutest name of a physical performance test. It's called the TUG. It's the timed up and go. Super cute. But it's a fall risk assessment. So I can do, in a matter of 20 seconds, I can risk stratify someone's fall risk. And if they're scheduled for treatments, and, we know women, breast cancer survivors, even up to 5 years out from treatment, have a higher risk of falling. And so there are risks that we can anticipate and be proactive about. And I think that that's another layer of support where rehab is that we can just be another group of individuals who are screening for maybe unknown risks, risk of lymphedema, evaluating their risk factors associated with lymphedema and the treatments that they have scheduled, and to try to help to mitigate and reduce that risk as well. I think that's is in any care team relationship. Communicate with your therapist, communicate with your providers. Something that's unique about every diagnosis is no one knows your body better than you, period. And so if there's something that, even if you don't have the words to put to it, like being able to communicate it to your providers or your therapist, because then they can help to bring you in on that conversation and navigate you if, as things develop as well.
I'll just add from the research perspective, there's really very little, there's actually a lot of evidence out there in the literature and guidelines that are available to our therapists showing how to reduce risk of exercise and physical and occupational therapy interventions. So from everybody from individuals who are getting a port, those who are at high risk of wound complications, and individuals who are at risk for falls and other issues. And so those are pretty widely accepted. Even individuals with bony metastases, we can safely exercise and train those individuals to have better outcomes. So there's a lot that we know now, especially over the last 10 years, about the risks of exercise and the risks of treatment. And so really using that information is how we deliver the best care. And sort of to kind of look at the opposite side, what we also know from the research evidence is that the risk of not being active is much higher. It's much greater, both in the short term in terms of the ability to complete and receive your treatment, but also in the long term in terms of risk of reoccurrence and length and quality of survival. So I really kind of try to think about, risks from both sides.
One of the things that you guys have both talked about, or the analogy that you brought up, is like if somebody goes and has a knee replacement, we would never expect them to know how to recover from that and how to adjust certain things. And I've never really thought about cancer rehab in the same way, but I think that was so well said. And now I think, when you say that and you think about cancer and you think about how it does change so many things about somebody's life, it just makes so much sense that analogy would be applicable to cancer as well. And with things like knee replacements and hip replacements, obviously rehab is more integrated, I think, universally, and it's also covered by insurance. Talk to me a little bit about where insurance coverage stands for cancer rehabilitation. Again, I know this is going to be it's going to be specific to what your plan is and things like
Sure.
that. But generally speaking, is this something that insurance plans generally will cover, or is this something that most patients have to pay out of pocket for?
So the short answer is yes. So most major insurance have rehabilitation services. So if your plan has rehab services for that knee replacement, those same rehab services can be utilized for physical, occupational, or speech therapy, because it is a skilled medical service. And so, for example, if we evaluated a patient for a prehab visit and they didn't have, we got their baseline and we're like, hey, you're good to go. I'm not concerned about any limitations. I would get them on a skilled exercise program, develop that so that they could safely move forward, and then just check in with them as needed. And that's another delineation I did want to make, because I've seen many patients who have their only rehab experience has been that total knee replacement or a hip replacement. They come in and they expect to be hurt, or they expect to have to come 3 times a week. And so I do want to make sure to make that differentiation, that this is a very individualized skilled service. And so the visits, you might see patients one time and then they're there as a resource. I'd say that's really far and few between, because most folks have at least one pre-existing issue or need some kind of guidance to be able to maximize their function throughout treatment or to manage side effects. But oftentimes we might see them early on, do that evaluation, get them on a home program, have them check in, or if they already have a lot of pre-existing issues, trouble walking, maybe they've had a history of falls, or they're a near faller, they're a furniture walker, they're holding on to the walls for stability. We might start that person on a program 2 to 3 times a week to really prep them, especially if they're going to have surgery, if they're going to have systemic treatment. So the frequency and the duration is really individualized based off of the patient's level and their needs. But thankfully, again, this is a skilled medical service and most major insurance plans do cover this. And also, the clinics will verify benefits prior to seeing a patient. So when a patient is referred by a provider, at least our process, when we get a referral, we'll check the patient's benefits and communicate them back to them prior to starting their visit. So there shouldn't be any type of surprises. The one thing, again, I would tell family and friends, and so I would like your community at large to know, again, another reason I'm very, very encouraging of an early intervention model is being aware of the financial toxicity that is the cancer experience. And oftentimes, if your medical benefits are in a calendar year, and let's say that your therapy benefits have better support or more coverage while you might have already met your deductible for that year. I always, it's always difficult for me if I see a patient and let's say they're 8 to 10 months out. Again, there's always potential. There's always something we can do. But sometimes it's even if they're like, well, darn it, I wish I would have come last year because I'd already met my deductible. So I think being mindful of that, my encouragement is driven primarily by the function and the outcomes that we can get when we have early intervention. But I also think it's really important that we understand that financially, it may also be the most affordable time for a patient while they're in that episode of care.
Yeah, and to add on to that, we're seeing in the research, some of our own research and some of the other research out there in the literature, that there is growing evidence showing that the earlier you start, the better your outcomes can be over time with using less services. So a lot of the research that I do is really related to this issue. How do we reduce financial toxicity at the level of the patient and also at the level of the healthcare system? And so that's a really big and important concern for us in rehabilitation, is making sure that we're optimizing the health, functional, and quality of life well-being of the patients while also not incurring any undue cost to the patients. So our goal is always to get you back as fast as possible and to discharge you out to a community exercise program or your personal trainer or whatever you like to do to stay fit and active. And so I think that that's a common misconception as well, you know, that we're constantly working to work ourselves out of a job, if you will.
Yep. And that's, I think, an example of that. So one of the most widely known side effects is lymphedema. So when I first started working in this space, I'd see patients with advanced lymphedema, and the cost associated with the supplies and the frequency of visits to manage more advanced lymphedema is astronomically different than when we catch people in early stage lymphedema. So like our prehab protocols. So again, to get kind of in the weeds and not to get specific to a type of cancer, because again, lymphedema can impact lots of different systems and lots of different body parts. But if I had a baseline measure and I could compare someone's volumetric measurements prior to intervention, I can catch it on, they might say, hey, I'm kind of feeling like fullness in this extremity or in this part of my body. Can you reassess? I can catch it so early now. And the amount of visits that the patient would have to be able to address that lymphedema, or the supplies required, which sometimes are not covered by insurance. So it just depends. But we're trying to be really proactive because I love working with this patient population, but I want them out the door and living their lives and
Right.
in the clinic as little as possible. And that's the objective.
I love this entire conversation that we've had here. And I know we could talk on so many of these different topics to different avenues, but one of the things that I wanted to kind of pause on as we wrap up here is to ask if there's any final tips that you would suggest to patients, or any final considerations that we should pass along as we kind of wrap up this episode here.
Yeah, I think that we've hit on a lot of the major points. One thing I'd like to reinforce is that, like Hillary said, it's never too late to come to rehabilitation. There's always something that we can do to help you. Again, our goal is to not keep you or burden you with a bunch of medical visits. It's to get you out in the world active, doing the things that matter the most to you. And so I think, really thinking about rehab in sort of 3 ways. So we can be preventative. We can help you prevent potentially a wave of a functional decline that might be coming your way based on any kind of treatments that you may be receiving. We can help you restore. So any functional decline that has happened, any deconditioning, et cetera, we can help you to really restore that and optimize. And then we can support you. We can help to alleviate symptom burdens and also help you to maintain independence and improve your quality of life. So that's really sort of kind of the roles of rehabilitation. A lot of people really just think about that restorative part, but we can really be your partner throughout the cancer journey to anticipate those declines and help.
That's a perfect summary of what we try to do every single day. And I think the point that I would just really like to hit on, we've already talked about, but it's just that be authentic in how you're feeling throughout your experience, and don't feel like you have to, I've seen patients again come in and minimize their side effects because they're grateful for the way that their treatment is going or how they're feeling that day. And I just want you to know, it's okay to be 2 things at once. You can still be really grateful, and you can still want to live your best life. And we want to help you do that. So I want to claim your quality of life, feel comfortable saying, hey, these are the things that are still, and then the same thing coming to the rehab professional. If we come and we evaluate you and I'm like, oh, that's not really my thing, or I don't really know that, my role then is to help direct you and to help give you more information to go to somewhere else. And so, I feel like, again, just having an assessment for someone, this is our job. It's my job to know if you have to pick up a 40-pound bag of dog food every single week, and if you can still do that. It's my job to know, if you like to fish. It's my job to know these things and to be able to help you anticipate. I don't expect my patients to be able to come and define all of these things. My goal is to help them understand our role in the cancer team and helping them to know ways that we can help to optimize their quality of life.
Yeah, I love all of that. When throughout this entire conversation and hearing the way that you talk about that too, knowing I myself have been that patient, right? That masks some of the small things that I'm dealing with because they feel small on the magnitude. And the one thing that comes to mind there of when I've personally been in those situations, and as we've been talking about this, is a lot of times it's the difference between some appointments are like to help me survive. Like that's what I think of, like getting through surgery, getting through treatment, like those interactions are helping me survive. And then the cancer rehab is like helping you thrive. Like, let's get back to life, not just surviving. So I love all of the feedback and all the suggestions from this podcast. And I'm very excited for patients to get this information. I know it's information that I wish I would have had earlier in my diagnosis. And I really encourage and hope other patients will kind of reach out earlier. And we talked about you can do it at any stage, but I hope especially patients that are newly diagnosed reach out and try to get this involved in their care as soon as possible if the resources are available. So I really appreciate you both joining, and I'm excited to kind of move this forward and maybe even continue any future conversations, because this is such a broad topic.
Well, thank you so much
for
again, having us, and also for just like prioritizing. I mean, I'm so jazzed that you guys would have this as a topic. And so, I mean, just this in itself, I can just imagine already how many people this might reach and just give them the courage to ask questions or maybe access the service. So thank you so much for putting this together and inviting us.
Yeah, it's been fantastic. You all have a great evening.
Thanks, you too.
Bye.